Welcome to this StudyNeuro lecture on ankylosing spondylitis, clinical presentation, systemic manifestations, and prognostic factors. Let's begin. In this session, we will examine how this disease presents in clinical practice, discuss its effects on the musculoskeletal system and other organs, and review the factors that influence long-term outcomes and quality of life. By the end of this lecture, you should be able to recognize the characteristic features of inflammatory back pain, identify the major axial and peripheral manifestations, and understand the important extra-articular complications that support the diagnosis. We will also review the structural changes seen as the disease progresses, the key physical examination findings, and the prognostic factors that help predict future disability. If you enjoy evidence-based neuroscience and clinical education, join the StudyNeuro community on YouTube, Facebook, TikTok, Instagram, and X for more high-yield medical content. Let's get started.
Ankylosing spondylitis is a long-term inflammatory disease that mainly affects the joints connecting the spine to the pelvis before gradually involving the spine itself, and with ongoing inflammation, pain and stiffness develop, while new bone formation may eventually cause the spine to become rigid. This process is progressive. This condition is the main form of axialspondyloarthritis and most often begins during the second or third decade of life, when many people are otherwise healthy and active, so the diagnosis can easily be delayed if the early symptoms are overlooked. Early diagnosis matters. Inflammatory back pain is often the first sign of the disease, and it may appear several years before changes can be seen on standard X-rays, making careful clinical assessment essential because starting treatment early can slow disease progression and help prevent permanent damage to the spine.
Inflammatory back pain is the most important clinical feature of ankylosing spondylitis and is often the symptom that first brings patients to medical attention. Recognizing this pattern is essential. The pain usually begins before the age of 40 and develops gradually rather than suddenly, while the symptoms continue for more than 3 months, making the condition different from short-lived mechanical back pain. Morning stiffness commonly lasts longer than 30 minutes. A key feature is that movement makes the pain better, whereas rest provides little relief, and many patients also wake during the second half of the night because of pain. Some develop pain that alternates between the buttocks, reflecting inflammation of the sacroiliac joints. Inflammation in ankylosing spondylitis mainly affects the axial skeleton, beginning most often at the sacroiliac joints before extending into the lumbar, thoracic, and cervical spine, while the joints connecting the ribs to the spine and the breastbone may also become involved. The spine is the primary target. As the disease progresses, patients develop persistent spinal pain and increasing stiffness, which gradually reduce spinal flexibility, make bending forward more difficult, and limit chest expansion during breathing, often leading to changes in posture over time. These changes build gradually. If inflammation continues unchecked, new bone forms between adjacent vertebrae, creating syndesmophytes that may eventually bridge the spine and result in spinal fusion with marked loss of mobility. Physical examination focuses on spinal movement and posture because these findings reflect the extent of disease involvement. Careful examination is essential. Patients often show reduced movement of the lower back, while extension, side bending, and neck rotation also become limited as inflammation and stiffness progress, making everyday activities increasingly difficult over time. These changes usually develop gradually. Posture also changes as the disease advances, with loss of the normal curve of the lower back, increased forward rounding of the chest, and a stooped posture, while severe disease may lead to flexion deformities at the hips and knees. Clinicians assess these changes using simple bedside measurements, including the modified Schober test, chest expansion, the occiput to wall distance, cervical rotation, and lateral spinal flexion. Although ankylosing spondylitis mainly affects the spine, inflammation can also involve the peripheral joints in about 1/3 to 1/2 of patients. The disease is not limited to the spine.
Peripheral arthritis usually affects one or only a few joints, often in an uneven pattern, and the lower limbs are involved more commonly than the upper limbs, with the hip, knee, ankle, and sometimes the shoulder being the usual sites. Joint symptoms may appear at different stages of the disease. Hip involvement deserves special attention because it occurs in about 1 in 5 patients, is closely linked with more severe disease, and strongly predicts poorer long-term physical function and disability.
Enthesitis is inflammation where tendons, ligaments, fascia, or joint capsules attach to bone, and it is one of the defining features of ankylosing spondylitis and the broader group of spondyloarthritis disorders. It is a key diagnostic clue. The condition commonly affects areas under repeated mechanical stress, particularly the Achilles tendon and the plantar fascia, although it may also involve the pelvis, chest wall, or the bony projections along the spine, making pain occur at several attachment sites. These areas are often very tender. Patients usually present with localized pain and tenderness, sometimes accompanied by swelling and morning stiffness, while activity often makes the discomfort worse. Recognizing enthesitis helps distinguish inflammatory disease from many other causes of musculoskeletal pain.
Ankylosing spondylitis can affect organs outside the joints, and the eye is the most commonly involved site. This complication is common. Acute anterior uveitis is the most frequent extra-articular manifestation, affecting about 1/4 to 2/5 of patients during the course of the disease, and it usually presents suddenly with a painful red eye, sensitivity to light, and blurred vision. The inflammation often affects only one eye at a time. Although symptoms usually occur on one side, repeated episodes may develop in either eye over time, so early recognition and prompt treatment are important to reduce the risk of permanent visual impairment.
Although cardiovascular involvement is uncommon, ankylosing spondylitis can affect both the heart and the major blood vessels. These complications are clinically important. Inflammation may involve the wall of the aorta and gradually enlarge the aortic root, which can prevent the aortic valve from closing properly and lead to aortic valve regurgitation, while the electrical conduction system of the heart may also become affected. These changes usually develop over time. Most conduction abnormalities are mild, but complete heart block can occur in rare cases and may require specialist cardiac management. Early recognition is important, especially in patients who develop new cardiovascular symptoms.
Ankylosing spondylitis can also involve the gastrointestinal tract because it shares important inflammatory pathways with inflammatory bowel disease. This association is well recognized. The two conditions most commonly linked with ankylosing spondylitis are Crohn's disease and ulcerative colitis, and affected patients may develop chronic diarrhea, persistent abdominal pain, weight loss, or rectal bleeding as intestinal inflammation becomes established. These symptoms should not be overlooked. Recognizing gastrointestinal involvement is important because it influences both the overall assessment of the disease and the choice of medical treatment. Ankylosing spondylitis may also be associated with skin disease, particularly psoriasis, because these conditions share similar genetic and immune mechanisms. The link is well established. Psoriasis typically presents with well-defined red plaques covered by silvery scales, and some patients also develop nail pitting or inflammatory joint disease known as psoriatic arthritis, reflecting the close relationship between these disorders. Skin findings may appear before or after joint symptoms. Recognizing these dermatological features helps identify the broader spectrum of inflammatory disease and can guide both diagnosis and treatment decisions. As ankylosing spondylitis progresses, chronic inflammation stimulates new bone formation along the spine, gradually producing syndesmophytes that bridge adjacent vertebrae and eventually lead to ankylosis, creating the characteristic appearance known as a bamboo spine. These changes are irreversible. At the same time, many patients develop reduced bone mineral density and osteoporosis, which increase the risk of vertebral compression fractures, while progressive forward curvature of the thoracic spine can further impair posture and function. These complications often occur together.
Unlike rheumatoid arthritis, which mainly causes bone and joint destruction, ankylosing spondylitis is characterized predominantly by excessive new bone formation, although bone loss remains an important feature of the disease. As ankylosing spondylitis progresses, increasing pain and stiffness gradually limit daily activities, making it harder for patients to walk, drive, dress, or look upward, while reduced mobility also lowers exercise tolerance and contributes to poor sleep and persistent fatigue. Daily life becomes more challenging. Disability tends to be greater in people who smoke, perform physically demanding work, or have several other medical conditions, and it also increases with longer disease duration and more advanced structural damage. These factors often work together. The impact extends beyond physical function, affecting emotional health, employment, and social participation, which makes early diagnosis and effective treatment essential for preserving quality of life. Several clinical features help predict how ankylosing spondylitis is likely to progress over time. Prognosis varies between patients. Poorer outcomes are more likely in patients whose symptoms begin at a younger age, in males, in smokers, and in those with hip involvement or a long duration of disease, because these factors are often associated with faster structural progression and greater functional impairment. Risk increases over time. Disease-related findings also provide important prognostic information, as early damage visible on imaging, syndesmophyte formation, persistent inflammation, and reduced spinal mobility all indicate a higher likelihood of continued progression. Structural damage already present at diagnosis is one of the strongest predictors of future radiographic progression. Ankylosing spondylitis is a chronic inflammatory disease that mainly affects the axial skeleton, and inflammatory back pain remains its most important presenting feature, especially in young adults, where early recognition should prompt evaluation for axial spondyloarthritis. Early diagnosis changes outcomes. As the disease progresses, persistent inflammation leads to spinal stiffness, reduced mobility, new bone formation, and eventually ankylosis, while peripheral arthritis, enthesitis, acute anterior uveitis, psoriasis, and inflammatory bowel disease provide important clues that support the diagnosis. Hip involvement, early disease onset, smoking, and existing structural damage are linked with poor long-term outcomes. Timely imaging and appropriate treatment can preserve function, improve quality of life, and reduce irreversible structural damage. Thank you for watching. Join the StudyNeuro community on YouTube, Facebook, TikTok, Instagram, and X for more high-yield neuroscience education and clinical insights. Please like, comment, share, and subscribe. Stay tuned for the next lesson.